Good morning, everyone. Today I've got some essential revision for MRCOG Part 2 slides. I've got some information for this from the guidelines and some of it from the TOG articles. Do hit the like button and subscribe to the channel if you haven't already. Also share this with your friends and colleagues who will benefit from this important revision. Also leave a comment below if you found this video useful and you'd like to see more in these series. So, syphilis in pregnancy, it's a bacterial sexually transmitted infection. Is caused by the bacterium, which is Treponema pallidum. Syphilis co-infection with HIV is uncommon, is seen in 40% of patients in the UK. Transmission is commonly through sexual contact. However, extragenital transmission can also happen via the anal, rectal, or the oral routes. Transplacentally can be transmitted at any stage of pregnancy. Risk is dependent on the stage of maternal infection and also the duration of fetal exposure. 25% of patients with primary syphilis who are not treated will develop secondary syphilis. With secondary syphilis, 30% will progress to tertiary or late syphilis. I will be putting up a whole video on syphilis in pregnancy so that we can cover this quite important topic in a lot of detail, as I remember that this is a very important topic that a lot of the questions in the exam get extracted from, so I think it deserves its own video as well. So, fetal ultrasound features for syphilis in pregnancy. So you see ascites, hepatosplenomegaly, intrahepatic calcifications, and placentalomegaly. Remember, these are fetal ultrasound features. So, simple ovarian cyst. So, what do we mean by simple? So, when we hear the term simple, the terminology, we're essentially saying that the cyst has got these 5 characteristics. So, it's round or oval in shape. It's got a thin or imperceptible wall, posterior acoustic enhancement, anechoic fluid, and absence of septations or nodules. So what do we mean if we say a cyst is complex, and that can be defined if one or more features are present, and those features are complete septations, that's multilocular cyst, solid nodules, and papillary projections. So calculation of risk malignancy index. So the formula is U times M times CA125 measured in international units per mil. U stands for ultrasound, scores 1 point for each of the following. So multilocular cyst, solid areas, metastases, ascites, and bilateral lesions. So U equals 0 for an ultrasound score of 0. U equals 1 for an ultrasound score of 1. U equals 3 for an ultrasound score of between 2 and 5. Menopausal status, so premenopausal is a score of 1, postmenopausal is a score of 3. And serum CA1 to 5 is something that you'd get the result on a blood test, and whatever the value is, you'd put the value in there and multiply all the 3 together to be able to work out the malignancy index score for the patient. So World Health Organization classification of disorders of anovulation. There's 3 types, type 1, 2, and 3. Type 1 is women with primary or secondary amenorrhea, low levels of endogenous gonadotrophins, and negligible endogenous estrogen activity. Type 2 is women with anovulation associated with a variety of menstrual disorders, including amenorrhea, who exhibit distinct endogenous estrogen activity and gonadotrophins in the normal range. Type 3 is women with primary or secondary amenorrhea due to primary ovarian failure associated with low endogenous estrogen activity and pathologically high gonadotrophin levels. So this is a table that kind of compares your different disorders of an ovulation and what you would find in terms of patient characteristics and the symptoms and also the hormone levels. So you've got your hypogonadotrophic hypogonadism, in which you have your FSH is low, LH is low, estradiol is also low, anti-Mullerian hormone is normal or low, ovaries are small or multicystic, uterus is small, endometrium is thin, body weight is normal or high, period pattern is usually primary amenorrhea. Hypothalamic amenorrhea, where you have FSH is normal or low, LH is normal or low, estradiol is low, AMH is low, normal, or high. Ovaries are small and multicystic. Uterus is small. Endometrium is thin. Body weight is low or lean. Period pattern is secondary amenorrhea. Hypopituitarism, so you have your FSH, LH, estradiol all low, AMH low or normal. Ovaries are small. Uterus is small. Endometrium is thin. Body weight is, it could be, any big, small. Period pattern is primary or secondary amenorrhea. Polycystic ovary syndrome, so FSH is normal, LH is normal or high, estradiol is normal, AMH is high, ovaries are polycystic or high volume, uterus is normal, endometrium is thick, body weight is any, period pattern is oligomenorrhea or secondary amenorrhea. So you can see how you can have a EMQ question where they can give a patient characteristics to say, oh, this is a 16-year-old patient and she's, for example, thin and from BMI perspective, and she has primary amenorrhea, and which of the categories do you think she'll fit into? And then they might give you a bit more description in terms of the FSH and LH values, and then get you to work out what disorder she's got, and then you can have follow-up questions from that. So I think it's just very, very crucially important to just know this table by heart, so you know exactly which category to fit your patient into. Um, and these are all the disorders of an ovulation. Right, so cytomegalovirus, again, a different video will be up for this as well in detail, because it's again quite well-liked topic for the exams. So it's a DNA herpes virus. It's a leading non-genetic cause of sensory neural deafness in children and commonly causes cognitive disability. The gold standard diagnosis is serology testing, so a blood test. 10% of infected women are symptomatic. That means 90% are asymptomatic. A lot of these symptoms that you get with CMV are non-specific symptoms, things like rhinitis, pharyngitis, myalgia, arthralgia, headache, and fatigue. So the patient may not even be tested. And pregnancy does not appear to affect the clinical severity of the condition. Migraines increase. So if you have migraines in pregnancy, there's increased more than twofold increased risk of preeclampsia, 17-fold increased risk of stroke, fourfold increased risk of acute myocardial infarction. If there is 3 to 4 headaches a month, then prophylactic treatment can be started in pregnancy, and it's safe even for lactation, and that's propranolol 10 to 40 milligrams at 3 times a day. Postural puncture headache. So you've got puncture of the dura that occurs in 0.5 to 2.5% of epidurals. If accidental dural puncture occurs with an epidural needle, there is 70 to 80% chance of a postural puncture headache. The headache is usually in the fronto-occipital region and radiates to the neck. It is characteristically worse on standing and typically develops 24 to 48 hours post-puncture. Conservative management includes hydration and simple analgesia. Untreated, the headache typically lasts for 7 to 10 days, but can last up to 6 weeks. Epidural blood patch has a 60 to 90% cure rate. Again, all these percentages, everything mentioned in this table is extremely important. So this is quite a useful table. It talks about contraindications of thrombolysis. Now this is from the Stroke in Pregnancy Talk article. Again, I'll be doing a separate video on this, as again, that is a topic that is very much loved and there's lots of questions that can come from it. So I will be covering that separately as well. But this particular topic and table here is quite important. So Absolute contraindications are intracerebral hemorrhage, suspected subarachnoid hemorrhage, neurosurgery had trauma within the last 3 months, systolic blood pressure of greater than 185, diastolic greater than 105, history of intracerebral hemorrhage, known intracerebral in arterial venous malformation, neoplasm or aneurysm, active internal bleeding, suspected confirmed endocarditis, known bleeding diathesis like platelets of less than 100,000, heparin within 48 hours, current use of warfarin with INR, that's international normalized ratio of greater than 1.7, direct thrombin inhibitors or factor 10A inhibitors, blood glucose of less than 2.8 or greater than 22.2, with resolution of symptoms when corrected. Relative contraindications are age greater than 80 years, National Institute of Health stroke scale of greater than 25 and coma, multi-lobar infarction on CT, previous stroke within the last 3 months, diabetes mellitus and previous stroke, minor or rapidly improving stroke, major surgery or serious non-head trauma within 14 days, gastrointestinal or urinary tract hemorrhage within 21 days, seizures at stroke onset, recent arterial puncture at non-compressible site, recent lumbar puncture, post-myocardial infarction, pericarditis, and pregnancy. You can see how pregnancy is a relative contraindication to thrombolysis. Okay, so this is a table comparing pregnancy and SLE-related changes. So a lot of the changes can be found even in normal pregnancy, but if you compare them to lupus, there are important distinctions. Things like anemia. In pregnancy, there's physiological hemodilution. There's also iron deficiency because of growing fetus. In lupus, there's anemia of chronic disease with hemolytic anemia. Proteinuria can be seen in pregnancy because of preeclampsia. Physiological increase of baseline proteinuria related to pregnancy or withdrawal of ACE inhibitors. In lupus, you see nephritis. Joint swelling and pain in pregnancy is mechanical arthralgia or effusion. In lupus, there is inflammatory synovitis. Thrombocytopenia can be gestational. You can have HELLP syndrome or preeclampsia. With lupus, you have immune thrombocytopenia, or you can have antiphospholipid syndrome. Facial rash in pregnancy, you can see melasma or facial blushing. With lupus, you have a malar rash. Seizure can be in pregnancy can be seen with eclampsia. With lupus, you can have neuropsychiatric lupus or cerebral venous thrombosis with antiphospholipid syndrome. Okay, so this is a important flow chart, and this is from the TOG article, Unscheduled Bleeding with Hormone Replacement Therapy. So patients on HRT and if they have any bleeding. So you are supposed to take a detailed history and physical examination, determine the HRT regime and duration. If it's sequential HRT, then and there's heavy, prolonged or breakthrough bleeding in more than 2 cycles, then you send the patient for a TV transvaginal ultrasound scan. If endometrial thickness is less than 7 millimeters, you just observe. If endometrial thickness is more than or equal to 7 millimeters, then you do an endometrial biopsy or hysteroscopy with biopsy. If the patient is on combined continuous HRT and they have been on it for less than 6 months, then you reassure if there's no other risk factors. If they are on more than or equal to more than 6 months of HRT, that's a combined continuous HRT, then you send them for a transvaginal ultrasound scan. Now, if the endometrial thickness is less than 5 millimeters, then that's just likely to be atrophic endometrium. But if the endometrial thickness is more than or equal to 5 millimeters, then you do an endometrial biopsy or hysteroscopy with biopsy. That's it. That's quite important revision covered for you. Quite important different topics for you to go and read if you haven't covered a lot of them in detail. But said a lot of these topics I will be doing separate videos for as well, so you can wait for them. And if you like this video, then don't forget to give it a thumbs up and also subscribe to the channel if you haven't already, and leave a comment if there is anything you would like to watch and what aspect of this video was useful for you. And if you would like to see these kind of revision videos where I cover lots of different topics together in one video, then please do let me know as well. Good luck revising.